your questions and answers. If you just click on the bottom Q&A icon on the bottom of your screen to submit any questions, we will save them all up and ask the presenter after they've presented. The conference is being recorded and will be posted on our website at a later date. And please feel free to share comments in the chat box that is viewable to everyone on the platform. So please just keep in mind that you don't want to share any personal medical information or personal questions. So I would like to take this opportunity to quickly introduce Alicia Estrella from the Estrella Foundation, and she's going to provide a welcome, and then she is going to pass the introductions over to Lauren Baer from our team at Mass General. So welcome.
Thank you, Kristen. As she said, I'm the president of the John Estrella Foundation for Cancer Research. And I just want to let you know a little bit about our foundation. It was founded in memory of my dad, John Estrella. Unfortunately, he lost his fight with kidney cancer in 2004. And that same year, we started the foundation. He was cared for at MGH, and he did participate in several clinical trials. Obviously with the idea that he would be paying it forward. And so this is the attitude that we founded his foundation. We are 100% volunteer run. We've been raising money for kidney cancer research for the past 17 years. And to date, we've raised over $250,000 to support kidney cancer research, kidney cancer awareness, and hopefully to help kidney cancer patients overall. This year, we're very excited because we are launching a new Helping Hand grant. It is a grant to help patients who need things that are not covered by insurance. They can apply for once a year to our grant for a little bit of help. We're very excited and happy to be able to partner with MGH and support this first kidney cancer focused webinar today. I really appreciate you for tuning in. Hope you find the information helpful. We would love to get your feedback today on how you thought the event was and things that you would like to hear about in the future. I thank you again for your attention, and I will turn this over to Lauren, who's one of the amazing counselors that they have working in the Cancer Center. Thank you.
Thanks, Alicia. So yeah, I'm Lauren. I'm one of the genetic counselors in the Cancer Center. And I just want to introduce our first speaker. Our first speaker is Dr. Jamie Jacobs. Dr. Jacobs is an assistant professor in the Department of Psychiatry at Harvard Medical School and a clinical psychologist at the Mass General Hospital Cancer Center. She's the director of caregiver research in the MGH Cancer Outcomes Research and Education Program. And Dr. Jacobs' research focuses on improving the emotional, physical, and treatment-related outcomes of patients with cancer and the individuals who care for them. She provides individual cognitive, behavioral, and mindfulness-based therapy in the psychiatric oncology service in the Cancer Center. And welcome, Dr. Jacobs.
Thank you so much, Lauren. Thank you for having me. I'm just going to share my screen, so if you'll give me a moment. Okay, can everyone see my screen? Great. So thank you again to the Estrella Cancer Foundation and to Mass General for having me today. I'm going to talk about really the emotional aspects of coping with risk of kidney cancer. As Lauren mentioned, I'm a psychologist in the Cancer Center. I do a lot of research that focuses on improving coping and improving quality of life for both patients who are being treated for cancer or their families. And so I think this really pertains to those of you here today who may be coping with someone in your family who has kidney cancer and the realities of the risk for yourselves, or perhaps the risk for your children or for other family members, and how you really live life with this risk and the ongoing implications of that. So I threw together some concerns, and I'd be really interested to hear from those of you in the audience a little bit more about what the specific concerns are that each of you individually are coping with. Often we hear about people being concerned about their own risk for developing kidney cancer or other related conditions. There's also risk for developing other types of cancer, concerns about children or other family members, like I mentioned, developing kidney cancer or other types of cancer. There's repeat imaging and screening that occurs, and several of you might have heard the term scanxiety, which has been coined by our patients over the years to refer to the ebb and flow of anxiety as scans approach or screening approaches, and then the time of waiting for those results, and then finally hopefully getting some good feedback, and then feeling like you've maybe gained some months or years on your life until you only have to be faced with, again, that buildup of anxiety and anticipation of being re-scanned or re-imaged. And so just acknowledging the normalization that is very normal and appropriate to experience, but also hopefully at the end of my talk, you'll have some concrete ways to manage that and to cope a little bit better with the anxiety and the stress that creates for you. Also, the possibility of being younger at the time of diagnosis is, I think, something that our patients are struggling with, and maybe the management of other related conditions or even benign tumors. The consequences of stress are many. Mostly we see an impact to daily and overall quality of life. There can be depressive symptoms or anxiety symptoms about worry that develop. Stress also places us at risk for more acute sickness, like colds or just feeling ill from time to time, or chronic illness, like increased cardiovascular disease or other implications of stress and the physiological of stress on our body. Also, social isolation. A lot of times when we're feeling stressed, we have a tendency to withdraw and to kind of turn inward. And so that really deprives us of the opportunity to experience positivity and the more helpful implications of social interactions. There can be weight gain or other sleep issues, and I'm sure we could go on and on about the effects of stress, but today is about coping. So I want to congratulate you for taking the next 20 minutes or so to focus on you and how can you improve how you're handling the stress around risk. So I'm going to leave you today, hopefully, with 3 very tangible, concrete ways to cope with stress and to cope with risk. The first is active coping. And I say this because we're all coping, and especially right now, every one of you is coping in some way with increased stress and feeling, stress is just what happens when our ability to manage something is less than the demands that are placed on us. So if you feel like the demands on you are more than your ability to manage them, then you are in a state of stress, and you might benefit from examining your coping strategies a little more closely and saying, what can I do to actually resolve the situation? Or if I can't resolve it, what might I do to minimize the stress or the discomfort that I'm feeling? And these are 2 ways that we talk about coping. In psychology, we love to classify things and give everything fancy names. So one way is problem-focused coping. So what action can I take? And the other way is emotion-focused coping. What can I do to manage the stress? I might not be able to fix it, but I can do something about my own physiological reaction and emotional reaction. I'm sorry, I think I exited out of full screen mode here. So were you trying to tell me, is someone trying to tell me that? Okay. I'm struggling with the dual monitor thing. So it's okay, you just saw a little preview of what my slides were in advance. So actually, I don't want you to see the preview because then you'll know how to answer these questions. But when we think about what can I control or can't control, I always like to bring it back to a snowstorm, and just bear with me for the simplicity of this for the moment. I don't want to be, insensitive to the gravity that comes with risk of kidney cancer, but I use this slide to point out that in any situation, there is always something that's controllable and something that's uncontrollable. So in a snowstorm, for instance, you can do certain things to control what happens to your house, to your car, to yourself if you have enough food and water and batteries. There are things you can do to make sure you're in the best position possible to weather the storm. But there are also things that are uncontrollable. How much snow there will be, what areas will get hit the hardest, whether there will be power outages and road closures and delays. So no matter what, we can always identify something controllable about a situation, something that you may have agency over. Now, when we think back to kidney cancer and risk of kidney cancer, we want to think about what can I control? And so this is where I was hoping that maybe we could have some people write into the chat, if I can view it here on my screen, and tell me, and maybe Lauren or someone will call it out since I can't seem to view the chat when I'm sharing my screen. But what can you control? Let's start with that. What are some things you feel you can control about your risk of kidney cancer? Give people a few moments to write in.
So our first entry was preventative measures.
Okay. Oh, and actually I can now see the chat somehow. It
Oh, great.
miraculously appeared. So great. So preventative measures. Yes. What can you do to prevent? Maybe there are some behavioral risk factors. I'm going to talk about those in a minute. Pick a doctor whom you really like and have confidence in. Stephanie said that. That's great. That's a really controllable thing. For some people, depending on where you live, that might be less controllable. There might not be as many doctors available. And so it's important to think, keeping your appointments. Yes. I love this. I love, Ellen, that you said this, because actually some people, when I say this to them, you have the choice to show up to your appointment. They say, oh, I don't have a choice. I have to do this. It's life or death for me. And that is true, but you still do have a choice. You still have that choice to get in your car, to drive to the appointment, to tolerate whatever imaging or screening, or if you have a diagnosis, to tolerate the treatment that might be pretty debilitating. So that is important to recognize that you have agency there. Diet, someone said diet, absolutely. What you eat, being physically active, having an ultrasound every few years. Another person said diet. Keep it in perspective. So I like that. That is going to be one of the things that we call an emotion-focused strategy. So when you can't do anything, it's how we think about something to try to keep things in perspective. And sometimes on certain days that can be easier than others. Just acknowledging that. Great. So we're going to move on to now, what do you feel is uncontrollable about the risk of kidney cancer? So people can also just write in a few uncontrollable things. These are usually the easier things to come up with. How effective treatment is, absolutely. Genetics, your own risk factors, whether or not you're positive for certain genetic mutations. Whether you get kidney cancer, absolutely, and when you get it, certainly. And we talked about sometimes age being younger at diagnosis, and so that is certainly a factor. Thank you so much for interacting with me on this. And so what I'll do is just go to my next slide where I filled some of these in anticipation of what you might say. So controllable, getting tested, encouraging family members to get tested, scheduling and attend important screenings, which you all said, talking to your children, having open conversations with family members about risk, and making healthy lifestyle choices, which you all mentioned, diet. So thank you for participating. And then uncontrollable, whether you're positive for a gene mutation, whether you have other related conditions or benign tumors that increase your risk, whether some of you said whether you will develop kidney cancer and when, whether a family member of yours maybe is resistant to being tested or not willing to have open conversations. So those are things that are less in your control. So going back to why we care about whether something is in our control or not, because that actually helps us to choose the coping strategy that will be most effective. If something's controllable, remember the things like diet, the things like taking preventative measures, the things like attending your screening appointment or getting your ultrasound, you want to choose a problem-focused coping strategy. These are things that all of us, I'm going to make an assumption here, but we tend to be really good at. Like, we can make a to-do list, we can make a decision, we can choose that doctor, right? Someone said. We can get more information from our doctors or from credible sources online. We can set a goal and problem solve or ask for help. These are things that you want to think of. I checked that off. I can do. Actions, actions. The uncontrollable things, those are when we want to turn to our emotion-focused coping. And someone in the chat mentioned taking perspective or keeping things in perspective. So these are things that you've acknowledged, okay, nothing I can do to change this, nothing I can do to, or I've done everything to minimize my risk. I've attended my appointments, I've taken my preventative measures, I can't eat one more healthy fruit or vegetable today. And so these are things you want to turn to reduce the stress now that you're sort of have done all of the problem-focused coping strategies. For all of you, these are going to be very individualized. Some people love being physically active and exercise is a way for them to manage stress. And for other people, this is not a good stress management technique. So I want to be really clear that these should be the things in this green box in the lower right-hand corner are the things that are self-soothing for you as an individual. That can be listening to music or playing music, any type of emotional expression, journaling, dance, talking, drawing, any type of art, therapeutic art. That might be more elaborate, but maybe for you, it's just taking a bath or taking a hot shower or watching the birds or being in nature, relaxation, taking a bike ride, talking to a friend, watching the sunset. So I want to be clear that some of these emotion-focused things can take planning and more effort, but other things can be really spontaneous. And I want them to be available to you to use when you're noticing that your distress or your anxiety is rising. Now, because we're talking about the controllable things and with regard to kidney cancer specifically, and some of you mentioned in the chat, there are things that you can do that are in your control that may reduce your risk, even with a genetic mutation. And the things that we know are related to risks of kidney cancer are cigarette smoking, obesity, and high blood pressure. I put on the right here how you would then want to mitigate that behavior that might increase your risk. And it might look simple on here, right? Just quit smoking, just eat more healthy fruits and vegetables. These are things that often we need help doing because these are either habits that we've formed over long periods of time or ways that we've learned to live. And it's not so easy to change overnight. And so the cigarette smoking, the most effective thing is usually to combine some sort of nicotine replacement, like a patch or other medication, with behavioral therapy, with cognitive and behavioral therapy to help you to manage urges and prevent relapse. And so with maintaining a healthy weight and increasing physical activity, there's a lot of data about how people can go ahead and do that effectively. So I would encourage you to talk to your doctor to maybe get a referral. We have a wonderful lifestyle medicine clinic at the Cancer Center that can help you with some of these things. Meeting with a nutritionist, the Cancer Center also has that resource available. So get help on these. Don't suffer or muddle through this alone if you're trying to really meaningfully reduce these risk factors for yourself. I want to give an example of coping. So when we use these problem-focused and emotion-focused coping, how does this really look for you when you're managing risk? In this example, someone is using problem-focused coping first before turning to their emotion-focused strategies, meaning they've checked off their things, they've attended their screening, and maybe they're waiting for results. And I've heard that sometimes it can take a few weeks to get those results back. And so that's a time that might be filled with high anxiety. That could be a time to then turn to the emotion focused and say, I did all the things I can control. So now I can't control this waiting period. I can't control that every morning I'm waking up and logging into Patient Gateway to see if my test results are there or waiting for that phone call. So we'd like to then plan maybe some pleasurable or distracting activities that can be, again, these self-soothing things that work for you as an individual. And that can be relaxing music or a funny TV show, or planning these things over the week so that you're reducing your emotional response to the stress. Coping can also work in the other direction, in which maybe you do the emotion focused first. So in this example, someone's making a decision about treatment, which can be controllable, but can also kind of take time and maybe, they're not sure whether or not they want to go for testing, or they're not sure what their next steps are going to be, and they need to take a step back. And this is like the example of sleeping on it for a night, right? Sometimes we need to take some space from a problem in order to figure out how we want to proceed. So in this example, someone is using that emotion-focused strategy first, and then saying, okay, now I'm ready. Now I'm ready to get the information, talk to my doctors, weigh my options, get the test, or whatever it is that I need to do. So that's how you can use these interchangeably. And just because we are talking about risk, and someone also mentioned preventative health behaviors, these are some coping strategies that we have all probably turned to at some point or another, but we tend to find them to be less helpful because in the short term, they might feel really good, like going to the container of ice cream or downing some wine or whatever it is. But in the long term, they don't tend to solve the problem, and they might even create more problems for us. So these strategies are okay to use with awareness. If you're, saying, okay, I'm just going to have a little bit of wine, and then I'm going to put the bottle away and turn to some more helpful coping strategies. Or if you're using them in a mindful way, like procrastination is different than taking a night to sleep on it and talking to some people before you make a decision. Procrastination is really detrimental long-term and can lead to denial. So I want to be clear that some of these might also increase your risk. And I would love to tell each of you, take a few minutes after this event tonight and think about, how do I cope? What impulsive ways do I cope with stress when I'm feeling stressed? And can I be more mindful about that? And are there other coping strategies that we talked about tonight that I want to integrate into my routine? The second thing I want to talk about tonight and leave you with as a concrete skill for coping with risk is setting an intention for self-care. So hopefully this helps you when you figured out what coping strategies you might want to use more of, thinking about what is something I used to like to do, and can I incorporate that back into my life somehow? I think this is applicable right now for the pandemic because we all have a lot of things that maybe we used to go to for coping that now aren't accessible to us anymore. And so I encourage you to think about, how can I cope differently, and how can I be creative about how I'm coping? And then what might get in the way? I love to take this time to think about what might get in the way, because if you think about the barriers to this up front, you're more likely to overcome those barriers. So then thinking about, how will I overcome that obstacle? If you're wanting to be more physically active and you're saying, I'm going to go for a jog every morning, but it's raining one day. Well, have a backup plan for what you're going to do if it's raining. What is your plan B going to be? And make that plan and stick to it. The most creative example that I have for this, and I can't take any credit, but feel free to print this out and try to fill this out yourself and do it with a partner. What is something I used to like to do? This couple that I worked with said they used to love to travel to new places. They couldn't travel right now. So they picked a TV show that was on, for instance, if they wanted to go to Greece, so they picked a show on Greece and Greek cuisine, and then they ordered takeout from a Greek restaurant, and they ate that food and they watched that show. And that was their way of spending time together and experiencing something new together and having a shared joy around that. I probably am not even creative enough to come up with this. So in this most simplest form, it can be, I want to exercise more. I'm going to, every morning before I sit down to work, I'm going to take a walk around the block. Or every lunch break, I'm going to stand and do some work standing. They can be really little things, but if you go through these steps and try to figure out how creatively can you incorporate that back in, it's a good way to improve those healthy lifestyle factors that will minimize risk. And the final thing that I want to leave you with is enhancing support. And I'll just say that we have many different types of support, both practical, people that actually help us to do things, emotional support, people that provide us with encouragement and warmth or hope, and then informational support that we might get from our doctors and our medical team and our amazing genetic counselors. Think of who your sources of support are and who's good at each of those types of support. So is your friend really good at the practical support here? Or is your friend better at providing that emotional support that you might need? So who are your sources of support? And then try to optimize that support by asking yourself these questions. Am I trying to do everything myself? Can I ask for help? can I ask a family member to come with me? And maybe not right now during the pandemic, but is there an appointment that you want someone to be there with you for, because it's stressful, because it promotes anxiety, and and maybe they can help you in the waiting time between getting the results back from some screening to help give you some healthy distraction. So notice the barriers that you might have associated with asking for help and receiving support, and then challenge those beliefs. Because whenever you're coping with something that's lifelong, and that's what I think is so unique about this type of risk, is that it is there with you every day, and it doesn't necessarily go away. And so finding ways to live each day, optimizing the support that you receive and being open to receiving that support, I think minimizes how much you're alone and how much you're withdrawing from others around you, and not being afraid that you're burdening others, because if you put yourself in their shoes, you might want to help you too. I'd love to talk about this more, but I know that we're running out of time, and I want to make sure that we have time for questions. So I wish you effective coping, and there are some resources here that I just like to stress. At the point at which, again, you feel like your ability to cope with stress outweighs the demands, that's the point to turn for more care. And there are great social workers and psychologists that are here to help you. Thank you.
Thank you so much, Dr. Jacobs. That was really great. I think you provided a lot of really good resources and food for thought for people to think about. But yeah, if there are any questions from our attendees, feel free, as Laura put in the chat box, put some questions in the Q&A, and I'm happy to read them off. So the first question I have here is about, let's see, does moderate alcohol drinking, i.e. wine, increase the possibility of catching kidney cancer? My father-in-law had a defect in SDHB that was passed to my wife and her siblings. So I guess it's just more maybe a physiological question that perhaps Dr. Iliopoulos could address later on in the conference. I don't know what you think, if that might be a more appropriate venue there.
I do. I think Dr. Iliopoulos will speak to that. And I think that what I'll say on that front is that I always like the term "can't hurt, might help." So, improving diet and lifestyle and reducing alcohol intake and other substances is only going to be helpful. And if you're struggling, especially with anxiety or depression, those are things that are sure to increase or maintain anxiety and depression. Mm-hmm. So I would, again, it's not always easy, but I would encourage you to try to find some other coping strategies for that, and try to find moderation in your own life so that you can both have the quality of life you desire and reduce risk for lots of different health conditions.
Excellent. And a more general kind of question is, how can I balance self-care with taking care of my family members that may also be at risk for kidney cancer?
That's a great question. This is important because, especially working with families, we can often be caring for other people so much so that it's at the exclusion of caring for ourselves. And I always like to think back to the put on your own oxygen mask before you help others. And so I think making sure that you have time for yourself, whether it's every day or every week, and being that this person that asked this is already mindful that maybe they're not taking the time they need for themselves. And I think that's the first step, is just bringing awareness to that balance. And that might be, I sort of rushed through my slides at the end with support because I know we're running out of time, but that is the time where I would say you need your own support. So you are providing the support to your family members, but who is the circle around you? And making sure that there are people that are only there for you, that you are the center of some other support circle. So you function for your family members in their circle, and then you need your circle, if that makes sense. Mm-hmm. And setting an intention for self-care that I talked about in that middle portion is important. That, I think, if you can go through those steps of what is it that I need to fill my pie of life, to make sure that I'm whole, if that is sleep or physical activity or moments of relaxation throughout the day. Sometimes it only takes 5 minutes to have a little bit of mindful relaxation. There's so many apps these days, like the Calm app, or other websites that you can find just to practice for a few minutes. Lock yourself in the bathroom.
And I think we have one more question here if you have a couple of minutes, Jamie, Dr. Jacobs. What are your thoughts about taking medication for anxiety, especially at night?
You know, medication for anxiety is very helpful. And I think under, you know, assuming that it's prescribed by your PCP or a psychiatrist that you're working with, I think, you know, that's a very individual question. I'm not sure if this person's referring to like an Ativan or a Xanax that is managing more of the acute anxiety. There are several antidepressants that are taken daily that are very, very helpful for managing anxiety, you know, to reducing baseline anxiety. So throughout the day, for people who are using anxiety at night for sleeping, using medication to manage anxiety at night for sleeping, I don't know what medications they're taking, but there are very helpful medications for sleep. And so I would just encourage that person to talk more with their prescribing physician about that. And if it is for sleep, cognitive behavioral therapy for insomnia is one of the evidence-based therapies that is very, very effective for improving sleep. So if they're looking to reduce the need to take medication, that's another thing that they can look more into.
Excellent. Thank you so much. Unless there are any other questions, we can move on to our next speaker. But thank you so much, Dr. Jacobs. That was really enlightening, and I feel calmer already.
Thank you for having me.
Thanks. Our second and final speaker is Dr. Othon Iliopoulos. Dr. Iliopoulos is a physician scientist, board certified in internal medicine and clinical oncology. He's an associate professor of medicine at Harvard Medical School. He directs the VHL and Hereditary Renal Cell Carcinoma Clinic, as well as the Hemangioblastoma Center, both at MGH, which provide comprehensive medical care to patients and families with hereditary RCC syndromes. The MGH VHL Clinic is recognized as a comprehensive clinical care center by the VHL Alliance. But Dr. Iliopoulos' laboratory at the MGH Cancer Center studies how cancer cells adapt their respiration and metabolism to the environment to outgrow normal cells. His goal is to discover novel and effective methods to treat renal cancer and hemangioblastomas, and he's the principal investigator in clinical trials that are based on his laboratory findings. Dr. Iliopoulos is also a member of the VHL Alliance Board and the chair of their clinical advisory board. And with that, we welcome Dr. Iliopoulos.
Thank you, Lauren. Good evening, everyone. I am going to take a moment also here to share my screen, and then we'll talk about hereditary renal cell cancers. As you can see, cancers is in plural because the hereditary tumors is a panel of heterogeneous and different diseases. So I can't talk extensively about the details of every one of them, but what I was hoping to do tonight is to give some short description from the most common forms of hereditary renal cell carcinoma. If you don't hear about your specific disease, it doesn't mean that it's not important. It means that, for the restrictions of time, I had to select some typical or more prevalent diseases. Then I would like to speak about surveillance for hereditary renal cell carcinomas, to analyze what is the rationale. Every tumor has a different requirements for surveillance, but there is definitely a common thread of thinking of how to approach surveillance. And then I would like to actually present you some great news about current treatments of renal cell carcinoma in the hereditary form and new treatments of renal cancer, and then give you a bit of a glimpse of what is happening in the future about the new discoveries in renal cancer. So by way of introduction, I would like to remind everybody, and I do this because sometimes you're going to be asked by your physician, or your genetic counselor, as we ask very often the people they come to us, what type of tumor you have, what is this type of kidney cancer, and people are startled by this question. I want to say that there are different flavors of kidney cancer. The majority of the kidney cancers are what is called a clear cell. You see here in the screen that they're called like this because the cells are appearing very clean and white inside. There are forms of kidney cancer that are called papillary. There are forms of kidney cancer that are called chromophobe or oncocytoma. This is how the tumors look under the microscope. And the pathologist who examines the tumor that receives from the surgeon classifies your cancer in one of these categories. Sometimes they have a problem to classify the cancer, and even in this case, this is quite telling. So what are, in brief, these forms of hereditary kidney cancers? I grouped them in 3 categories based exactly on this type of how they look like under the microscope. The first category is the very prevalent in the population that we see, VHL disease. The clear cell carcinoma tumor is very characteristic for them. And then there is a group of cousins of the VHL that they have a clear cell appearance, but not exactly that clear cell appearance. They appear a little bit more atypical. And these are tumors and patients that they have alterations and mutations in other genes that the VHL, BAP1, MITF, or succinate dehydrogenase genes. The second family are the tumors that the pathologists are going to be in the category that says papillary, and these are mutations in the c-MET, fumarate hydratase, and PTEN gene. And the third one, the fourth one, is the disease that some of you probably heard or have, which is called Burke-Hogdibet disease or tuberous sclerosis tumors. So let me go quickly and describe some of the clinical characteristics, and this is not to teach you the disease, of course, that you're having, everybody's familiar with this, but communicate to each other some common elements that they exist among all the patients, that they have even different hereditary renal cell carcinoma, and also to make some comments about the prevalence, how frequent is the kidney cancer in this type of diseases. VHL disease, patients that they have VHL disease develop hemangioblastomas, and they also develop renal cell carcinomas. And as many of you are very familiar with, they develop kidney cancer throughout life. They can be bilateral, they can be multiple spots of kidney cancer. I'm going to take 1 minute and close my mail. So they develop multiple kidney cancers, but not everybody is going to develop kidney cancer in VHL disease. Only about 50 or 60% of the patients will develop kidney cancer. People that they have BAP1 germline mutations, they are at high risk of developing renal cancer. They can also develop melanoma of the eye or melanoma of the skin, and they can develop a third type of tumor, which is called mesothelioma. Mesothelioma is a cancer of the lining of the chest cavity and the abdominal type of cavity. Unfortunately, I cannot provide you a number how frequent would be the renal cancer in BAP1 patients. It is not very clear. It's probably not very high. It's probably a bit less frequent than the VHL patients, but it is a considerable risk. The people that they have MITF germline mutations, they develop kidney cancer, but the percentage of the patients with this type of mutation that develop kidney cancer is going to be very small. As a matter of fact, there have been some studies that they provide or shed some doubt as to whether or not kidney cancer is at increased risk in patients with MITF germline mutations. We do not see it very often, but it's something that's worth keeping an eye on and screening for. And then we move to the other cousin of this clear cell carcinomas disease. These are patients that they were told that they have hereditary pheochromocytoma and hereditary paraganglioma syndrome. These are a group of mutations that they develop in proteins that they work in our mitochondria, which is the factory of the energy in the cell. And when these proteins happen in the genes like the succinate dehydrogenase B, C, D, A, and other partner of these genes, patients are at increased risk to develop pheochromocytoma or paraganglioma. These are tumors that they develop in the nervous system that does not control our muscles. In the nervous system that moves our gut, blinks our eye, allow us sometimes to swallow. There is a set of nerves that they develop this type of tumor. They develop tumors in their intestine and the stomach that they're very typical, and they are called GIST type of tumors, renal cell carcinoma, and small adenomas, non-cancerous growth in the pituitary gland, which is in the middle of our brain. Not all mutations are equal. People that they have mutation in gene B are having higher risk to develop this type of tumors, and these tumors may be more aggressive than people that they have mutations in D, in C, or in A. As a matter of fact, probably the people that have mutations in the SDHA may have the minimal or no risk of developing renal cell carcinoma. And then there is the new member of the other group, of the group of the papillary tumors. People that they have mutations in the fumarate hydratase gene, they have a 5% to 40%. You see that the difference is very big, but this is because in some studies, in some populations, people have only 5% chance. In other populations that has been detected higher, 40% chances of developing renal cell carcinoma, which is a type 2 papillary tumor. The same members of the family or relatives of these members can develop uterine fibroids or these benign skin lesions that are called leiomyomas. They can be tender sometimes. They're clearly not cancerous and they're clearly not dangerous. Let me emphasize that the patients with FH germline mutation are not at higher risk for developing any uterine cancer. They're not at risk of developing any skin cancer. They are at risk of developing renal cell carcinoma only, and the other ones are benign lesions. They also have the possibility to develop paraganglioma and pheochromocytoma. And then the disease that it's a mix of everything. This is a disease that has been discovered lately, or actually the gene has been identified lately. It's called Burghoff-Diebe disease. Many of you may heard of it or have it, and it's caused by a mutation in the gene that's called folliculin. And the people that they have this mutation develop these skin tags, very characteristic lesions in the skin that are called fibrofolliculomas. You can see it here in the picture. They develop cysts in the lungs that spontaneously they pop, and they develop renal cell carcinoma that is a mixture of all the previous histologies that I mentioned before. As a matter of fact, many times the pathologist says, I cannot classify this tumor. I know it's renal cell carcinoma, but I cannot put it in a specific bin. In most of these cases, I say, I can, and Lawrence say the same. This is probably Burghoff-Diebe disease, and more often than not, we're right about it. As it happens with all the disease that I mentioned so far, the patients do not have to develop all of the symptoms. They don't have to develop all of the lesions that they're associated with disease. They may develop some of the lesions, or the cases that they may not develop any of the lesions at all. And this germline mutation kind of remains silent. So how do we look for this type of renal cell carcinomas? What type of surveillance we do and why we do the surveillance? Well, clearly we do surveillance once we know that somebody has the mutation because we want to catch these cancers when they are small. And the reason is that when we remove or treat otherwise these cancers when they're small, we do not have the risk, the patients do not run the risk to have metastatic disease which can threaten their life. Whom do we screen generally? Well, we screen by genetic testing any person who has a family history of the hereditary disease. We screen any person who has a family history and a single lesion of the hereditary disease. My father had HLRCC, fumarate hydratase mutation, and I think I have a leiomyoma. That almost certainly makes a diagnosis, but we screen this type of patients, and we screen patients that they don't have a verified family history of a disease or a personal history of a disease, but they have two of these lesions, a renal cell lesion and a lesion out of the kidney, that makes us suspicious that this lesion is not a random garden variety type of tumor. For reasons that they have to do with the prevalence, with the frequency of the mutations in very specific populations, we also screen patients that they may have one pheochromocytoma or paraganglioma, a hemangioblastoma, which is a benign tumor of the brain linked to the VHL disease, a pancreatic neuroendocrine tumor, and any patient who has a spontaneous pneumothorax, spontaneous, not traumatic type of pneumothorax. The question that we face a lot of times is, okay, we screen the patients. At what time do we test our kids for this type of mutations, if we have to test them, and when do we start surveillance? Well, first of all, we test the kids at the time that we will modify our clinical practice. So if we're not going to have to do an MRI until the kid is 25 years old, we are not going to test the kids particularly before this age. If we are going to look at the hemangioblastoma that develops in the brain of the VHL patients and starts at the age of 9 or 10, we want to test the kid a little bit before this age so that we know that the MRI, we start the MRIs the right age. So when do we start the MRIs? We start the MRIs a little bit before the time that we know that this is the early onset of the lesion, which is associated with a genetic type of kidney cancer. So we know that the renal cell carcinoma in VHL starts around the 17 years old, late adolescence. We know that folliculin, the earliest that had produced a tumor in the kidneys, is in a 15 years old kid. And for the other type of tumors, the BAP1, SDH, and MITF, we start at around 17 years old. As you can see, mid to late adolescence, we start looking for renal cell carcinoma. That does not mean that mid to late adolescence, the time that we screen the kids for a germline mutation, we will screen them also at a time that we will cover the other tumors that may be associated with the disease. And this is very important detail. And based on the onset of tumors, the age of the tumors appear, we provide specific protocols per disease. And here, for example, you see the protocol that we're using, the VHL and hemangioblastoma clinic at the MGH for a different age of the individuals that they're having the disease. So how do we screen? We screen usually by imaging of the kidneys, and we don't like to image the kidneys with a CAT scan. We like to image the kidneys with an MRI, because the MRI does not have radiation, and because we do not like to radiate people for a lifetime, as the people that are going to be screened if they have a predisposition to develop cancer. So I'll take the moment here to try to address some points of concern and questions that are frequently asked around how safe are the MRIs, when can we use them, how they relate to pregnancy, and so on and so forth. How safe are the MRIs? The MRIs are very safe. We do need to have a functioning kidney, though, to have an MRI. The contrast that we're using for the MRIs, and I have to emphasize that most of the time the contrast is very useful. We may be able to do MRIs without contrast, intravenous contrast, and have them informative, but most of the times we need the contrast to have a very accurate information, need a good kidney function, because it is excreted by the kidneys. So there is a number that indicates how well our kidney is working, and this is the glomerular filtration rate, the rate by which our kidneys clean the blood. And if that drops below 30 cc's per minute, we do not like to give IV contrast because it has been associated with a complication of skin disease that's called nephrogenic systemic fibrosis. There has been a lot of literature and a lot of concern about the cumulative effect of the MRIs lately, because the concern was that the contrast of the MRIs is deposited in different tissues. There have been quite good studies, and we think that the MRI and the American Society of Radiology thinks that the MRIs are very safe. The linear type of contrast, the second generation of contrast, is not deposited in the tissue, and most of the centers now, they're using the second generation of contrast, not because we had any strong evidence that the previous one was damaging the tissues, but because we wanted to get away completely from any doubts and any concerns that the literature has generated. So MRIs are safe as long as you have a good kidney function. They don't have to be abused. They can be done for a lifetime, and we prefer to use linear intravenous contrast. Can I do an MRI if I'm pregnant? And by the way, does pregnancy also affect this type of tumor growth? There have been many of anecdotal reports, and there have not been very solid studies, but to make the story very short, it appears there is no indication that pregnancy by itself will accelerate necessarily the growth of any of these tumors. MRIs without contrast are safe for the fetus and the mother at any trimester. Gadolinium that can be used, or any other IV contrast in the first trimester, has been associated though with increased side effect in the kids. Therefore, we don't use IV contrast for the first trimester of the pregnancy. As a matter of fact, the current guidelines is to avoid to do an MRI unless completely necessary and mandatory during the first trimester of the pregnancy, and maybe not during the whole pregnancy. Women that they give birth to babies can resume their MRI screen afterwards. The MRI contrast accumulates minimally to the milk, and essentially is not even absorbed by the gut of the newborn. Therefore, the recommendation is, out of a great precaution of safety, do the MRI, just don't collect milk and don't breastfeed 24 hours after 48 hours after you are doing the MRI, again, out of the great precaution. So where are we standing with the treatments of these renal cell carcinomas? There are two categories generally. There are good players and there are bad players. Good players means that the renal cell carcinoma in this type of inherited forms grow relatively slowly, and they can be observed until they reach a certain size. And of course, people that they're not very familiar with, but most of our audience probably here is very familiar with, will ask the question, why would you have to observe these tumors? And the answer is that patients with an inherited type of tumor, they may develop kidneys over lifetime, and we don't want to go often in the kidney and remove the tumors because we damage the good kidney. And in the end of the day, we want to preserve the kidney function, and this is the major concern. We, of course, want to make sure that the tumor is not going to metastasize out of the kidney. So the good players are VHL and BHD. And we all feel comfortable to observe in the MRIs of the patients multiple tumors, renal cell carcinomas, until they reach a size of 3 centimeters. And at this size, the cutoff, we interfere. We interfere by removing them by surgery or by cryoablation, by RFA, or, as I'm going to show you in a second, with another type of treatment these days, the medicine. The BHD also tumors have very benign behavior. I have patients that they have multiple tumors that between 2 and 3 centimeters in each kidney, and we're not doing anything. We're just following this type of tumors because most of the time also they don't have a linear growth. They sleep for a while, they grow again, they sleep for a while, so on and so forth. But they're bad players. And these bad players, the worst of all these bad players is the tumors that are associated with the fumarate hydratase mutation. This is the HLRCC syndrome, the people, they have these leiomyomas and the kidney cancer. The approach here is very simple. You see it, you remove it immediately. It doesn't matter how big it is, it doesn't matter how small it is. A millimeter enhancing lesion that the radiologist tells you that this is maybe tumor, you remove it immediately. This is because these tumors grow very fast and get out of control. There is an intermediate category, the tumors that are associated with the succinate dehydrogenase mutation, BAP1 mutation, and MITF. We don't treat them with the aggressiveness that we treat and the alarm that we treat the fumarate hydratase, but we don't let them grow to 3 centimeters. Essentially, we arrange for some removal of these tumors as soon as we see them. The surgical approach to the kidney cancers, hereditary kidney cancers, had evolved dramatically in the 1980s because the patient was going to develop kidney tumor. They were removing the kidneys, and of course, the patients were suffering great morbidity and mortality from transplantation or from hemodialysis. Later on, surgeons in the field realized we don't have to remove the tumors. We don't have to remove the kidney. We can remove only the tumor. That's okay that another kidney tumor is going to exist. Please don't remove the kidney. And then the early 2000s, we all realized that until the tumor reaches the 3 centimeters of disease that I mentioned, there is no risk, and therefore we observe the tumor. So now we're entering a completely new era in the 2020s, and this is where we essentially treat the tumors with a new medications or medications that they're targeting the lesion in a very specific way. And that gives me the opportunity to remind every parent that it's in the audience that most likely the years to come, the way that these lesions will be treated in their children will be dramatically different. And the world of inherited kidney diseases is changing dramatically. Here is the example. The drug is actually under FDA consideration right now for treatment of patients that they have VHL and renal cell carcinomas. Many years of research in which we have been involved showed that VHL is a protein that kills another protein, HIF-1 alpha in the cell. All these renal carcinomas, the VHL patients don't have VHL, and then this guy, the hypoxia-inducible factor, goes wild, and this renegade somehow needs to stop. So a company that's called Peloton at the beginning, now the drug has been passed to Merck, develop a small molecule, a pill that patients can take through the mouth. But what it does is that it goes and lodges between HIF and its brother, and this type of interaction is necessary for HIF to work. And by doing this, it kind of breaks apart the HIF family, and therefore it neutralizes the HIF. So all these tumors may not have the VHL that keeps HIF at check, but then there is a drug, there is a medication that keeps the HIF at check. We just sent a few months ago an abstract in which we describe these new medications called MK6488, and MGH has been actually actively playing a leading role in the clinical trial of the VHL patients, and the news are very good. About 27.9, let's say a third of the patients will have significant shrinkage of the tumor if they take the medication once a day through their mouth. This is called partial response. That means the tumor has been shrunk to 30% or less, and the overwhelming majority of the patients will have the tumor stable. Look at this graph that has been almost non-imaginable a few years ago in the VHL patients. In the left side, we plot here the tumors that they increase over time. Here is when they start the patients taking the medication, and what happens is that the tumors stop growing over the next 2 years and 2 years that they have, or they're decreasing. And if we can put this in numbers to make it even more clear, for 520 weeks, which means 10 years almost before the treatment, the tumors were increasing by 3.5 millimeters every year. And after the application of the treatment, the whole group, they started decreasing by 6.5 millimeters every year. So I have very little doubt that this is going to be the next treatment for kidney cancer in the VHL disease, and maybe treatment for other inherited type of cancers. I doubt it's going to be for fumarate hydratase, of course, for reasons of safety. I am getting close to my time here in presenting, but I'm going to give you a little bit of a glimpse of the world that's probably coming after these HIF-2 alpha inhibitors. The research in the inherited forms of kidney cancer has been accelerating discoveries, and we have been in my lab actually part of these discoveries, and I'm proud of it, but the main reason that I'm showing is to tell you that there are multiple angles by which the kidney cancers are going to be, the inherited kidney cancers are going to be attacked. I'm not going to show you science to our audience. I'm putting this for me to remind me to hit some high points. One of them is that we talked about one inhibitor, one HIF-2 alpha inhibitor. There are many companies and many academic laboratories that they develop several now new, novel, different ways working inhibitors. And the reason I'm saying that is that when I talk to the patients about it, the first concern I can see in their eyes of somebody who deals with a chronic disease is, oh, and how much this inhibitor is going to keep my tumor in check? Do I develop resistance to this inhibitor? Well, like everything else in oncology, at one point, maybe we're going to develop resistance to this type of inhibitor. But the good news are there are different other mechanisms that they will attack and destroy HIF that they're actually pioneer right now. We have developed one of these drugs in the lab, and we're getting very close to preclinical trials. The other approach that we developed in the lab, as Lauren mentioned at the beginning, is that we studied cancer metabolism. It turns out that the cells that they don't have VHL, they have a completely different way of metabolizing all the substances that the VHL positive cells. So if you're losing your VHL, you don't depend on your glucose for the turbine of your cell to go on. You start depending on other things, which is glutamine. So remember, if you're a normal cell, you depend on glucose. If you're a cancer cell, you start depending on glutamine. So we showed very nicely that if you use specific inhibitors, that they starve the cells for glutamine because they attack enzymes that they process this glutamine to the cell, you can make the VHL tumors in animal models completely collapse. And this is now in clinical trials. People all over the country, and we have done it for renal cell carcinoma, but we're also doing it for hemangioblastomas. They take tumors, they chop them out, and they now don't study the biology of the tumor anymore. They study the biology of a single cell out of the tumor. And my lab has done this with hemangioblastomas. We collect them from the OR, we make tissue cultures, and we sequence the DNA and the RNA of a single cell. And somehow we deconvolute the interactions that they happen between the cells. Like you don't fly above, you don't see a city in the map, you are actually flying with a helicopter in a close proximity, and you can start seeing the traffic, the interaction, the important points in town, and therefore it gives you the opportunity to target them. I'm gonna skip this. And the big news that actually I think some members of the audience ask about it is the immunotherapy. The blue cell is the T cell, this is the dendritic cell, this is the tumor cell. The tumor cells have antigens that our immune system recognizes and attacks them. But in order to protect themselves, they have all these flags that they inhibit the T cells, our immune system, from attacking them. And as you know, these days, there is a series of antibodies that they block this interaction. They kind of go and lodge in between the tumor cell and the T cell, and therefore the tumor cell cannot inhibit the T cell anymore of the immune system, and the immune system can attack. We haven't used this. This is extensively used in cancer these days, but it's primarily used for metastatic type of cancer. We haven't used this for localized type of cancer. Our ambition, our hope is that patients that they have been taken care of by specialized centers will never have to face the metastatic disease, but the cancer will be under surveillance and will be stopped and operated and interfere when it's localized. Therefore, there is not a lot of literature about it, although it's available in the case that we see patients when they're coming in late stages, and thankfully we haven't seen many of them, and we see them in early stages. But this is another big weapon in our shelf of available agents to combat inherited types of kidney cancer. So at the MGH, we have patients referred for various reasons. Some of them because they have a family history, some of them because they're having kidney cancer at a very young age, some of them because they have all these extra other lesions besides the kidney that make people suspicious of hereditary disease. And according to their type of histology, as they have as explained to you, we're going and look for specific germline mutations, and we create a comprehensive program to follow them and the members of the family that are at risk, so that the tumors remain at check and they're not metastatic. This is my lab that has done the basic science work. Many labs in the world work on this. Lauren is the genetic counselor that works with me in the clinic, and it's a great opportunity. Most of the patients in the audience know her, to thank Lauren for helping me and partnering with me in running this operation. That's it. I think.
Thank you so much, Dr. Iliopoulos. That was it's a lot of really exciting things going on with kidney cancer research and inherited cancer research. That's really exciting. I think, we have some time for some questions here. We have about 20 minutes. If anybody has any questions to add to the Q&A, happy to read those off. We do have a few that have come in. If you're okay to field a few of these, Dr. Iliopoulos. So the first question actually came during our first initial talk with Dr. Jacobs, and the question was about, does moderate alcohol drinking or intake increase the risk for RCC?
Let me answer a little bit in a broad way regarding nutrition and kidney cancer. We do not have specific information for the inherited forms of kidney cancer. There are modifications. There nutritional habits that we do know that in the general population increase the risk for kidney cancer, and these are, as Dr. Jacobs mentioned, tobacco use, smoking, alcohol, and BMI, obesity. There is clear evidence that for people that they have a BMI above 30, there is a clear increase. There is, as a matter of fact, there is a vertical exponential increase for development of various cancers. We don't have anything that we know based on a clinical trial for inherited cancers. And there is a counter argument in the case of inherited cancers that your genetics may trump the environmental factors, and whatever you do, you will be always susceptible. I like to err towards the side of great caution and say that if I have a genetic predisposition, at least I would like to minimize every other additional factor, and therefore I would highly recommend to exercise, not to smoke, to drink healthy food, to reduce the BMI. I would not go as far as I say, don't drink anything at all. I think that one glass of red wine, particularly of good quality, every night, I think it is a very good thing for the human beings.
Thank you. One question that came up also was, what kinds of tools do you see in the future for alternative methods of detecting tumors? We know finding cancers earlier. Is there any blood screening that you think could be a reality? Or
We do know that the mutations of patients with inherited types of kidney cancer, the mutation is detectable as a free DNA. There is a possibility that the mutation is detected, that there is a possibility that there are circulating cells in the blood. People do use these tools and these approaches right now to answer the questions, can I detect it early? Or the more important question, the more kind of troubling question, can I predict an impeding growth of this tumor? Unfortunately, we don't have any biomarker that tell us which of these lesions, once they present, will remain dormant and which of these lesions are going to increase. And this is not a theoretical question. It's a very practical question. For example, I can imagine that I would not like to give this HIF2 alpha inhibitor in a VHL patients forever in their life if they don't have any kidney tumor. And maybe the best time to give it is when the tumor is going to grow. So if I was able to detect this impeding growth of the tumor, maybe would actually uncover the most vulnerable stage in the life of the tumor. No biomarkers available, but many groups work on circulating DNA and circulating tumor cells to validate them as biomarkers of disease progression.
all right, thank you. So a question came in through the Q&A. What do you consider a good schedule for follow-up with you for a person with a CMET germline mutation and recurrence in a second kidney?
I would recommend probably, well, if the tumor is present, I would remove the tumor. And then in a tumor-free patient, I would recommend surveillance with an MRI of the kidneys once a year. The good thing for a CMET patient is that they are not at risk of any other type of lesions out of the kidneys. So therefore, they can focus their attention on the kidneys and follow them once a year.
Makes sense. And what doctor should oversee surveillance of individuals at risk of inherited kidney cancer? Primary care doctor, a kidney specialist, or another specialist? What would you recommend?
I mean, this is like asking a pianist what type of music they like. I mean, I'm tremendously biased, but I, in all honesty and seriousness, I think that patients that they have an inherited form of kidney cancer, they should see a specialist. I don't think that anybody can blame primary care physicians or generalists not to having the specific knowledge of how to follow these patients. And it's not only theoretical knowledge, it's actually accumulated experience of how to handle the disease. So I would refer them anywhere they are in specialized centers for inherited kidney cancer.
Okay, makes sense. Gotcha. Another specific question about one of these genes. Have you seen RCC with an ATM germline mutation? It was a clear cell RCC, and papillary architecture sounds like in a person with RCC and a family history of RCC. No other genes were detected.
So it is actually a very interesting question, because the easy answer a few years ago would be that there is no association between the ATM germline mutation and kidney cancer. In recent studies, particularly metastatic type of kidney cancers, there has been some increase in the mutations in this family of the proteins that they have to do with recombination of the DNA. So I would keep an open mind here, and I would be a little bit cautious. Currently, my answer would be no, but there is a possibility that in the future we revise this type of connection and we come to realize that tumor proteins that they have to do with DNA recombination, like ATM or CHEK2, may confer some higher risk for kidney cancer. Maybe not as high and as prominent. That's why the reason that they're not very obvious to us right now as other type of tumor suppressor genes like the VHL. But if you put them in the correct context of genes, in a combination of genes that you get from mom and dad, and you have a germline mutation in the ATM, there is a possibility that this type of mutation bleeds into the tumor.
And we know genetics is an evolving field, and as we do more research and more testing of these large panels, we're going to learn a whole lot more. This is an interesting question that came in registration. Do you know where Birt-Hogg-Dubé syndrome is found in the world and where it isn't?
Yes, somebody sent me this question, as you said in the registration. It's a very interesting question. I don't. I have no idea where it doesn't exist in the world. I can tell you where it exists in the world. It exists in Europe. It exists in Eastern Europe. It exists in Russia. It exists in Asia. There are reports from Japan, from China. I do not know it has been detected in Africa. It has been detected in Canada and South America. So pretty much I think it exists everywhere. Now, if there is any area in the world that it has not been reported, doesn't mean that it doesn't exist, but there is a possibility. I mean, the person who asked probably the question also read the fact that Birt-Hogg-Dubé is an extremely rare disease and only 100 families have it in the world. This is an old information. We know that now that Birt-Hogg-Dubé is more frequent disease. I mean, we see several families in our center, and clearly I don't think that it accounts for a quarter of these 100 families in the world. I think it's a widespread disease. It hasn't been recognized because it has a more benign innocuous profile, and therefore it doesn't cause the morbidity that would have flagged it years ago.
There was a comment in the chat as well that there's a good Facebook group for BHD that you are, I believe, a part of as well.
Yeah.
That could be a good resource for other people who are looking for information or just to share experiences. Let's see, what other questions do we have here? So one question was, at age 77 with a pathogenic variant in the FH gene, what are the risks of doing nothing? Have no other symptoms of the kidney issues. What do you
Very
recommend?
good question. I would say low. I would say very low. I think that the FH germline mutation gives cancers between 5 and 40% of the cases, and somebody arrive at 77 without any problem. I would say extremely low. I would not say none, though. In all practical terms, I would recommend to this person who asked the question to occasionally have an imaging of the kidneys. And if for reasons of anxiety, as we discussed before, or for reasons of other diseases, or cannot do an MRI, I think another form of imaging the kidneys would be an ultrasound. It is quick. It is not in close quarters. It is inexpensive. I would recommend that they image the kidneys once in a while. That question though brings me to another important point. I would not recommend to the relatives of this person who is 77 years old to also assume that they will not develop any tumor until they become 77 years old because of this member of the family. For all inherited type of tumors, we may see significant different behavior and aggression between one member of the family to the other. Therefore, I would not extrapolate and assume that if my brother, sister, mom, or dad did develop or did not develop the specific inherited syndrome-related lesion, that will also follow the same pattern. Clearly, we have seen completely different pattern of lesion evolution within the same members of the family. I would follow the guidelines and discuss that with my physician independently.
That's a good point. That's a, yeah, it's a, one wants to look to their family for more, to learn more about this gene, but it could be very variable within a family. So that's a really good point. A question just came through the Q&A. When is the new drug expected to be approved by the FDA? The $1 million question.
No, I don't think it's $1 million question. The company was bought for 2.2 billion. I think it's much more expensive.
Orders of magnitude up.
Yes. Of course, I don't know, but the data we have is that Merck filed for the medication. FDA currently is surveilling sites of clinical investigation. They do visits to make sure that what we say that we wrote is correct. And the drug has approval for an expedited review. Expedited review by definition means that you have to have your response from FDA within 6 months. The drug was filed in February, and therefore I believe that probably by July, August, we should have one way or the other answer from the FDA. And again, as I said, I think that based on the data, I can express my personal and only personal opinion, emphasize this for legal purposes. It's hard to believe that the drug is not going to be approved. So I think by July or August, we will have it.
Great, very exciting times in RCC research. A good question came through the chat as well. It's more about if we don't know, if there is no genetic testing or there's negative genetic testing, but there is a family history of kidney cancer. Do you recommend screening, or what kind of, I'm sure it's individualized, but how do you approach that?
Yeah, Lauren and I struggle through this question with patients every Monday. And the answer is yes. So again, everything has to be discussed with specifics, but we don't know, I believe we don't know all the genes that predispose for kidney cancer. There may be genes that we don't know. There may be also other ways to deregulate these mechanisms that they involve these genes other than mutation. For some reason, you don't have a mutation, but your protein is destroyed and it doesn't exist in the cell. So if there is a strong family history of kidney cancer and no test or the genetic test negative, I would still consider that this patient that belongs to the family is at significant risk, and therefore I would recommend that they image their kidneys. And our usual way to approach this is that we recommend to start the imaging of the kidneys 10 years before the earliest onset of the kidney cancer in the family. There are no hard scientific or clinical data to support this in an ironclad way, but this is life. It's an imprecise thing and quite imperfect, and I think that when it comes to health, we're more cautious. Therefore, I would screen these kidneys.
Sounds very good. And I think we may, unless there are any other questions, we may be ready to wrap up here. But yeah, Kristen, I'll hand it over to you.
Thank you so much, Lauren. Thanks, Dr. Iliopoulos, and to Dr. Jacobs for such an amazing educational symposium. Thank you so much. I also want to thank Laura Hines from our team, who has been essential in putting this webinar on, and a huge shout out to Alicia Estrella and Susan Hahn from the Estrella Foundation for their generous support of this educational activity. And most of all, I want to thank you all who have logged in and attended. Just a reminder that it has been recorded and we will put it up on our website so you can log back in and catch up and do another glance at Dr. Iliopoulos' talk so you can take some more notes. Thank you all so much for coming, and hopefully you will be getting in the mail or in the email a evaluation form, and we would really appreciate any and all feedback that you have for us on this particular symposium. So thank you very much.
Good night, everybody. Thank you.
Great job, guys.
Thank you, Dr. Iliopoulos. That was great.
Thank you so much.
Bye, everybody. It was my pleasure.
Thank you.
Thanks, Othon.
Bye, Kristen.